Good evening and welcome to ISRT YouTube live streaming. We have a special speaker for tonight's live streaming and we are so honored to have him as the guest speaker. I'm very excited to introduce Mr. Sundar Kalyana, General Manager from Wipro-GE Healthcare. So he will be speaking on improve your CT imaging tips and tricks. So before beginning the session, let me announce that there will be a question and answer session after his live talk. So please feel free to type your questions in the comment box and Mr. Sundar will be answering those questions after his talk. Over to you, sir.
Hey, thank you, Mahesh, for the great words. It is my pleasure to be in front of you once again. I pay my respect and my love and affection to all my respected teachers, my guides and guru, senior technologists, who helped me to learn all through my life and still learning them, the technologies, what they taught. Thank you so much. And of course, great appreciation to the entire radiology technologist community for their great war against the pandemic. And you have lived more than the expectation. And thanks a lot for that. And no words can uh, uh, give an applause to this because it's beyond it. And thanks a lot. Great work. Continue. And wish you all next year should be a good year for us, and that's all of us pray to the Almighty too. And wish you all a great, prosperous 2021. With that, I'll enter into the live session. Today's topic is on how to improve your day-to-day work in CT. Some tips and tricks, and what I learned along with my rest of the team all through many years of working with different type of CT scanners. Thank you so much. All of you. Let me first of all thank the whole family members of ISRT for giving this great opportunity to once again chat with you on methodologies to improve your CT scan in your day-to-day life. Without much wasting the time, I'm straight away getting into the presentation. So today's topic is imaging with CT, how to improve it using some very simple, easy to follow tips and tricks. As you know, when you do a CT scan, there are many variables are there which you put as parameters during the scan. Some of them are controllable during the scan, like MAS, KV, PG, or SFOV, or the field of view, etc. Certain other things are controllable during the reconstruction. And there are a set of other pieces which are all patient related. Improving image quality involve one or many of these parameters to be adjusted by the technologist, customized by the technologist during the scan. As you know, patient to patient, there is difference. So as the scan parameters, as well as the technique you use to achieve the desired clinical outcome. One of the major parameters which decides the image quality is called the noise. I put two images in front of you, one on your left side and one is on your right side. What you see on the left seems to be very noisy. So just to say what is noise, it's nothing but the dark and white pixels, what you see all around that image, obscuring the visualization of good anatomy behind it. Whereas on your image on the right is from the same scan, but the noise is taken care of by some methodology. We will see them and we will use some of them to improve our image quality in our day-to-day scanning. Noise, as I said, degrades the image quality a lot. But before attacking the noise, you should be able to measure the noise. How we can measure it? It's not a very complex process also. It's very simple for you to measure it. As you know, when you put in an ROI to measure the Hounsfield unit, what actually we are measuring along with is something called standard deviation. Every CT scan gives this. And this standard deviation is a straightaway measure of the noise. There are many parameters which can be controlled during the scan to help you to reduce the noise. That include KV, MAS, the slice thickness, the pitch, the reconstruction algorithm, and usage of the later development called reconstruction, and many more things. Which of these parameters to use and where to use, how to balance, that is a task which is relied upon you. We will go one by one. First, we will attack effect of MAS on image quality. As you all know, MAS determine nothing but a quantum of photon that reaches the patient, passes through the patient. And of course, end of the day, they fall on the detector and are responsible for the image quality. If you're increasing the MAS, that reduces the noise a lot, but with the penalty of increased dose. The great thing, what increased MAS do for you is it will increase the low contrast detectability. I'll talk about low contrast detectability, or called LCD, in the next slide. Now you may ask a question to me, what MAS I should use, or what MA and what rotation time I should use. The rule of thumb is the selection of MAS depends on your clinical task. For example, if you're looking at a high density tissue interface like bone air, or in terms of like chest, where you look at the vasculature versus the bronchoalveolar region, you can actually reduce the MAS. We are not looking at the soft tissue difference. Whereas if you're looking at liver lesions, where the lesion has a very low difference in Hounsfield unit compared to the rest of the liver, you may need to use a higher MAS to improve the low contrast detectability. It all looks very difficult when you want to select what right is right to be selected for the case in front of you. Very interestingly, today almost all the CT systems uses automatic exposure control. We call it as auto MA and smart MA, and that algorithm will deal with it. Okay, so your task is actually very less. But we should know what noise index we need to put. We will see that in the following slide. There is two examples in front of you, two images are in front of you. One is done at 50 MAS and other one is done at 100 MAS. You can know that the noise index, or the standard deviation of the first image, which is done at a lower MA, is 15.5, whereas with 100 MAS, it is 11.5. And you can see a marked difference in the image quality. When you use the 100 MAS, the noise in the liver is gone, and you can see very good homogeneously distributed liver, whereas here you see a lot of noise on the lower MAS image. That means increasing MAS will reduce your noise, but when you're increasing MAS, it has a detrimental effect that it increases the dose, which is evident from this dose report, which you can see there down there. You can see the CTTI with the 50 MAS is 3.9, versus when you done the scan at 100 MAS, it's almost double. It is 7.8. So to get a good quality liver, you may need a higher MAS. to reduce, that reduces the noise. Now, what is the relation? There is a good statistical relationship there between the noise and the MAS. The noise is proportional by root of MAS. To just simplify that, if you're reducing the MAS by half for a scan, you increase the noise by 40%. And also, very interestingly, you reduce the dose by 50%. Or the reverse, if you want to improve the image quality by 40%, you have to increase the dose by 50%. Okay. They're not in direct proportion, as there is a root to variant is there. Okay. We have dealt so far with MAS as a single parameter, but S also has its own importance, especially when you do a moving organ like heart, where a shorter rotation time will improve your temporal resolution, which is very important in capturing the moving heart. The slower rotation will create more motion artifact compared to a short, fast rotation speed. So keep a tab on the S part or the rotation time part when you do especially regions which are susceptible for movement. Now let's get into the effect of KVP. As you know, KVP is nothing but penetration, but it will improve the noise for sure. But very interestingly, unlike the conventional radiography, in CT you have very limited choice of MA stations. Typically, they are 80, 100, 120, and 140 kVp. Increasing kVp will reduce the noise. Of course, as you know, in radiography, it reduces the contrast differentiation. In CT, also the story is the same, nothing different. And increasing kV has a great effect, especially in when you scan regions like brain, where you have dense skull bone, which attenuates a lot of X-rays. So use of higher kV, like 140, will help you to see the boundary between the bone and the brain. So the suggestion will be to use a higher kVp for adult brain scans. The detrimental fact is that it increases the dose. Now, we have to go for a balance. So the balance is very simple. Use 80 or 100 kV for pediatrics. Use 100 kV for contrast body studies and for angiograms, especially for patients with a moderate to lower BMI. We will see those with some clinical examples. So here we have taken 3 slices done at 80, 100, and 120 kVp. And you can see the noise index is noise or the standard deviation is reduced from 22 to 15 when you have moved to 120 kVp. One thing which I invite you to observe in this image, you can see a bit of iodine pooled there in the calcium system. And that is faintly seen when you've gone to 100 kVp, and when you've gone to 120 kV, it's hardly seen. That means what? Reducing kVp will help you to see better contrast enhancement. You know, there is a calculation which says that compared to 120 kV scan, if you're using 80 kV scan for a contrast investigation, you get 70% more contrast enhancement. And when you compare that to 100 kV station, which is more practical in your day-to-day life, you can improve the contrast visualization by 25%. In another way, I can say this can help you to reduce typically 25% of volume of contrast injected, or this will enable you to use a low iodine density contrast. Let's see how this works on a routine brain. Here you have 4 images in front of you done at 120, 140, 120, 180 kVp. When I moved from a high kVp image to a low kVp image, you know that the noise is definitely increased. is very much visible for you. And the other part, if you look closer to the bone brain interface at 80 kVp scan, the differentiation is less and you are getting some cup artifact coming up there. Whereas in 140 kVp, the bone brain boundary or the barrier is seen very well. And this is especially important, especially when you look at some uh, thin SDH like this. So to reduce the beam hardening effect in adult brain, it's better to use a higher kVp than a low kVp. And as you see in the previous slide, a contrast investigation like an angiogram, if you do it with a lower kVp, will give you better contrast augmentation. Here is an example of doing peripheral angiogram. Of course, these are two different studies, but one done at 120 kVp and another done at 100 kVp. The interesting fact is that you're able to see much more smaller muscular branches of the vessel, and overall density of the vessel is better with 100 kVp. Here are a few clinical examples in front of you. These are all done at 100 kVp. As a rule of thumb, whenever you are using 100 kVp, when you are using lower kVp, there is a chance that the noise may go up. To offset that, you can use iterative reconstruction. It's called as or equivalent. Increase that by 10 or 20%. So use of 100 kVp is better for angiograms, but remember to use iterative reconstruction to offset the noise. So it helped you to reduce the contrast volume what you inject. Typically 10 to 20 ml per investigation. Even though we don't recommend the volume here, but in our experience, we have seen it. Just to summarize so far what we have seen, there are many user controllable parameters which can improve the image quality, especially the noise factor. It decreases with increasing MAS, it decreases with increasing KVP. Higher KVP is good for bone-brain barrier. Lower KVP is good for augmenting the contrast and reduce the dose and reduce the contrast volume or the concentration of iodine. Whereas lowering KVP, as you know, will increase the noise in the image. And of course, the S part is MAS part, the S part of the MAS will affect the temporal resolution. Now we will move to the second part of this. What about slice thickness? So far we have seen the scan parameters. Now let's see the slice thickness. As you know, increasing slice thickness will increase the voxel size. Increasing voxel size definitely will reduce the noise. This is true with any imaging modality. But increasing slice thickness will give partial volume effect. Very interestingly, if you increase the slice thickness to a moderate to minimum to moderate level, that will improve your visible contrast differentiation. You can see 1 mm slice and a 4 mm reformat in front of you. So really you can see the structural differentiation and the noise pattern is much better on a 4 mm slice compared to 1 mm slice. So for a reformat, it's better to go for a 4 mm slice than a 1 mm slice and say that I got a noisy image. In a multi-slice CT where you do isotropic voxel acquisition, your reformats with a slightly thicker slices will be of great use in the day-to-day clinical practice. But unfortunately, if you're using thick axial slices to do a reformat, that will look like this. So remember, whenever you are doing any reformat and want to get a better image quality, I would suggest to go for the thinnest possible slice and then do a reform thick slice in the reformat software. Now we'll get into another parameter, which actually is mostly ignored many times. I really don't know why this is being ignored. Is field of view. There are What is field of view? It's the area which you reconstruct or you scan. Okay, in simple terms. There are two field of views are there. One is called DFOV or displayed FOV or reconstructed FOV. And the other one is called SFOV or the scan field of view. If I represent them in two circles, this is how it will look like. SFOV is the area seen by the X-ray beam all around. That means if your anatomy is within SFOV, you can get an image. If your anatomy is not within SFOV, you cannot get that image. DFOV is the area which you use for reconstructing. That means to improve the image quality, to improve the resolution, you may confine your reconstruction to a smaller area and get a better image. And that is determined by the DFOV. We will see them in detail. Most of the CT scanners depend on the vendor. There are different selections of scan field of view is possible. In GE system, you have pediatric head, pediatric body, small head, head, small body, medium body, and large body. There are different scan field of view, and these all are decided by a special filter which is there near X-ray tube called the bow tie filter. I'm not getting into those details, but we will see the effect of using inappropriate SFOV for an anatomy. Here are two head images in front of you. One is done with a scan field of view of 25 centimeter and reconstruction field of your DFOV of 25 centimeter. This is how a normal brain in CT look like. Absolutely good, no artifact. Unfortunately, if you use the scan field of view of 43 centimeter, which is large, and use a large FOV of reconstruction, you get a bad image like this. You know that it's having a low resolution. And also, if you observe, where I put the red arrow, you can see artifact, a red, a black colored line all around the brain bone barrier. So this is because of uncorrected attenuation which has happened there because of beam hardening, and which clearly says that use of large scan field of view is not good for small anatomy, right? Many times, whenever a spine CT is asked, what we do is we take the image and then even from an abdomen scan and then zoom it, use the magnification and then give an image like this, right? So here is a recon done at 43 centimeter and with a magnification factor 4.2. Is it good? Now we will see what happens if you use a dedicated reconstruction field of view rather than using simple magnification. Whether will it improve the image quality or not? Let's see that. You look at the first image. You see the bone boundary is not very good. You see pixels there. Whereas when we have put the same image reconstructed with a smaller reconstructed field of view of 15 centimeter at a lower magnification factor, this pixelation is gone and we got an improved image quality. So as a tip to you, I would always recommend to use the very appropriate scan field of view and the very appropriate reconstruction field of view confined to the region of interest or area of interest when you are making an image, rather than zooming the image and giving the result. So even on your day-to-day life, you can improve image quality a lot by reducing the right or the selecting the right appropriate scan field of view and reducing the right appropriate reconstruction field of your DFO. A very complex scan parameter called pitch. In one word, if you ask me what is pitch, it's nothing but it determines the speed of your scan. Pitch, as you know, is a ratio of table speed per rotation divided by the collimation. as theory. Now, in practical terms, very interesting fact, many of the CT scanners doesn't have much of varied choices of pitch. They have 4 or 5 clinically available pitch. Depends on the collimation you use and the detector coverage you use. In terms of what should be the pitch selection, it's purely depend on the imaging task. And one thing which you have to ensure that the breath holding capacity of the patient is within your scannable time, so that the whole anatomy is scanned within a single breath hold. So you may have to use mostly a high pitch scan for almost all patients. Very interestingly, today's all new generation CTs have very strong algorithm which would take care of the image quality, especially something called the pinwheel artifact, which comes from high pitch usage by using image quality improvement method like IQE, so that without any limitation, you can use a very high pitch. So keep in mind, whenever you are doing any scan, ensure patient movement is minimum and you select the best possible pitch to cover the whole anatomy, especially in a single breath hold, so that artifact related to motion is minimized because of your short scan time enabled by high pitch. Another parameter which makes a lot of quality difference on your day-to-day life is spatial resolution. Knowingly or unknowingly, we do select the protocol which is appropriately set in the system, and then use those parameters to get the right spatial resolution. Just to touch upon this, spatial resolution is nothing but the ability to visualize two very dense objects which are very close to each other and differentiate them. And increasing the slice thickness will reduce the spatial resolution. In other words, you have to use thinnest possible slice to improve the spatial resolution. Spatial resolution improves with the high pass filter, but you may lose your contrast resolution. Very interestingly, as you have seen in the previous slide, use smaller field of view of reconstruction, because all your CT images are phytal by phytal matrix, most of the scanners. And to improve the size of the pixel, you have to use the minimum possible field of view. As a recommendation, I would suggest to use isotropic submillimeter protocol as much possible for small parts, and for large body part like abdomen or chest, you may use 1 millimeter or slightly larger slice thickness. So whenever you need high spatial resolution, the recommendation is to use smaller reconstruction field of view and use a high pass filter. We'll see what is the high pass filter and its effect. So here is a submillimeter isotropic image in front of you showing the smallest bone, the stapes. And these are done. You can see the axial images is seen on your screen on your left side, second quadrant. And you can see the reformats, which are the obliques, the sag, and the coronal, which are all having the same resolution of the axial. So this is what is called the submillimeter isotropic imaging. This may not be possible to replicate submillimeter isotropic imaging all across anatomy in a day-to-day activity, but for smaller regions like IAC temporal bone, please use the very appropriate submillimeter isotropic protocol. Effective reconstruction algorithm, we will see that in a nutshell now. Which algorithm you should use for reconstruction? It depends purely on the clinical task. For example, if you want to look at soft tissue we will go for softer standard. If you want to look at chest or the lung, we will use lung or the chest algorithm. And if you are looking at, if you want to see the bone fracture, we will use the bone algorithm. It's very simple. And in some vendors, it is called by different numbers. In G system, this is how it is called. Very interesting fact is that when you are going from soft algorithm to the edge algorithm, it increases the spatial resolution. And the other side, you can see that edge algorithm has a higher noise compared to the soft algorithm. So which one you will use for what clinical task? We will see some examples. So here are four brain images done with a different reconstruction algorithm. The first one is done with soft, the second is with standard, third one is with detail, and the fourth one is with bone. So which one you will select if you want to see the soft tissue detail, which is gray-white differentiation in the brain, and to see the content inside the thick bone of the skull. You can see soft is too soft, loss of resolution is there. We may use a standard reconstruction algorithm or a detailed reconstruction algorithm, which gives you adequate gray-white differentiation. Whereas if you're using bone reconstruction algorithm to display the soft tissue of the brain, the image looks very noisy for you, right? So appropriate selection of the recon algorithm is an essential part, depends on your clinical task. Now, in this example, I put four images. Here we want to visualize bony detail. Definitely from the images is clear in front of you that you may use bone algorithm or the edge algorithm to improve the visualization of the bone. Many times I have seen technologists uses the soft tissue image, just change the window width and level and put it as a bone image. I would recommend you to use bone or the edge reconstructed images. It's a 2-second job for you to go back to the raw data and do a reconstruction so that you can improve the image quality a lot. Let's see some clinical example. The first image is reconstructed with the standard image, but put in bone window, put an edge enhancement filter. Whereas the second image on your right is done with a dedicated bone algorithm. You can see the fracture lines are well visualized on the bone image compared to your soft tissue image with the changed window width and level and the spatial filtration. So to improve the resolution and the bone interfaces, it's better to use a high pass filter algorithm like bone. Same thing happens with chest also. You can give a beautiful chest like this, but the resolution is less because you use the standard algorithm. We do have a certain algorithm called hybrid algorithm called chest in GE system. With a single algorithm, you can get both mediastinal detail and the lung detail very well. Now, which data set you will use for creating a 3D? Whether you will use a bone reconstructed algorithm image for creating a 3D, or you will use a soft algorithm used for creating a bone 3D. In every practical circumstance, it's better to use a standard or a soft reconstructed image to create a volume rendered 3D. Here I'm putting two images in front of you. One is done with the standard algorithm and the second one is done with the bone algorithm. You can see the bone algorithm 3D image throws a lot of artifact compared to what is done with the standard algorithm. If you want to still improve the resolution, the sharpness of your 3D volume rendered images, you can move from soft tissue to another algorithm, slightly higher up, high pass filter algorithm called detail, which can help to see the fracture visualized well in the 3D. Just to summarize what you have seen so far is thinner slice will help you to improve the spatial resolution, but of course at a higher noise levels. And optimal slice thickness is essential, depends on the clinical task. The formats can be of thicker slice. They will improve the visual spatial low contrast detectability or low contrast resolution, as well as reduce the noise. Use of appropriate scan field of view and display field of view, very, very important. Whenever you are doing a 3D, use soft or standard algorithm for creating a bone 3D. Once again, I repeat, if you want to get a bone 3D, please don't use bone algorithm, use soft or standard algorithm. Pitch, as we have seen, is mostly all the scanners today are capable of high pitch helical without any compromise on image quality, because there is a great backbone they have to take care of the pinwheel effect. So pitch is not a real factor because we are all today at a very high pitch scanning. Many times, this is something very interesting which I want to bring in front of you. Many times when in my clinical practice, I used to set everybody scans with two scouts. One is an AP scout and other is a lateral scout. You can see 90° and 0°. And in practice, what I have seen, technologists go there and keep one scout selected and then delete the scout. The reason being, if you delete the scout, according to them, you save some radiation dose and also you save some time. Is it right? Let's see. The reconstruction in CT is done by taking views all around the patient, right? Very interestingly, the body is not a perfect circle. Rather, it's an ovoid shape. Your anteroposterior diameter is less than your lateral diameter. That means to get the uniformity of the view, you have to change the MAS or the photon count or the photon flex. When you move from anteroposterior to lateral, you may have to increase the MAS. And when you come to MA or MAS, and when you come to again back to the post to anterior, you may have to reduce it, and then go to other lateral, you may have to increase. So this is something called smart MA. So within the slice, the system varies the MA. The other thing which you have to observe is from head to toe. If you take, for example, here we are doing a chest scan, chest and abdomen. The chest region has a lot of air inside. Do you need a very high MA to image chest? You don't, right? So when you are setting your auto MA protocol, the system reduces the MA when it sees a low density tissue. And when you go to the abdomen or the pelvis, which is high density tissue, the system increases the MAs. How would you do this? The modulation of the MA on the anteroposterior dimension to the lateral dimension, as well as from the supro-inferior dimension, is done from calculated from your scout scan. So when you do two scout scan, the system do this calculation. That's the reason why you should not delete one scout. Please allow the system to take two scouts and determine your auto MA and smart MA. Now, we will see, I'm just keeping a slide here. We will see what the effect of auto MA and smart MA. There are two scans in two dose report in front of you. This is the same slices, same region scan, and you can see the DLP is 234, and when you used auto MA and smart MA is 198. The first one 234 is with auto MA, and this one is with smart MA. So to enable smart MA, you may need two scout. So that's the reason why, to get the best result without spending much of photons or much of dose, it's better to do two scout. You may save approximately 25 to 30% of patient dose, overall scan dose, just by taking two scouts. In the beginning of the session, we have seen what is noise and how you set the noise index. Noise index can be set by typing the appropriate value in the field given in your scanner, right? You may get confused also what value I should type here. Okay, I'll just start with an example here. You see one scan done with 7.4 as a noise index and other one is done with double of that. It's 14 as the noise index. And if you look at how the MA is modulated, when you're given a lower noise index, the MA used is much higher compared to when you're done with the high noise index, the MA used is much lower. That means an increased noise index will reduce the MAS. Of course, when you reduce the MAS, what will happen? Your noise in the image also will go up. Now, what should be the appropriate noise index to be selected during practical scan? Ideally, a noise index of 10 to 14 for a 5 mm slice and the contrast enhanced scan is the appropriate selection of noise index. But whenever the system allow you to check the MA table, please check the MA table that MA is modulated well. You can see the variation of MA all across the slices. You should see this. That means system is very well adjusting the MAs according to the anatomical differences from the scout scan. So that's called MA modulation. So a selection of 10 to 14 as a noise index will help you to see the soft tissues and contrast studies. Whereas the high density interfaces, as you have seen, where the more noise can be accommodated, you can use a noise value from 15 to 25 when you are looking at, say, bone or lung, etc. And many times, slice thickness. We may set the protocol with a 0.625 mm slice in the system. And many technologists think that thin slice scanning in today's multi-slice CT will give more dose compared to a thick slice scanning, and they immediately change the slice thickness from 0.6 to 5 mm. This is a case of a renal angio. So what has happened? The system, your scanner, is well calibrated that when you change your slice thickness from, say, 0.6 to 5, you can see the MA is dropped down to very low value of 45. And if you try to do a reconstruction with 0.6 mm from this scan, you may get a very noisy image. So please check the MA value if you change the slice thickness from a set protocol. And one more interesting thing, whether you scan with thin slice or you scan with thick slice, your dose doesn't matter for a given MAS. Okay, so there is no point in changing with a thick slice for an angiography scan and say claim that I can reduce the dose. No, it's not right. Very important thing is patient centering. If you change a patient's position within the gantry by about 4 to 6 centimeters from its isocentric position, the dose required to maintain the image quality goes almost like 40 to 50%. So what it means? You must use the right appropriate patient center very close, very proximal to the isocenter. That's very, very important. It can be done easily with your 2 laser lights, one in the frontal and 2 from the lateral side. Please center the patient's anatomy closest to the isocenter. That can help you to improve your image quality and reduce the dose by about 50%. Another very interesting fact is scan what is required. Many times we do overscan. Is it required? We don't know. As technologists, many times radiologists may not be present during the scan, and we simply follow the straight away the protocol than the clinical need. For example, here is a scan where you want to see only the KUB. Technologists plan from somewhere below the chest to below the diaphragm, below the pubic symphysis. Is it required? Actual scan area is required. This can enormously reduce the dose to the patient as well as the equipment usage. So limit the scan area as much possible. Another very interesting practical tip for you is giving auto voice and a manual voice. Very interestingly, what we have seen, the recorded voice doesn't match the instruction what you are given to the patient when you're putting the patient on the table. So you can see multiple things: Shasam Nirtu, Shasam Pidiku, Shasam Nirtike, Shasam Valichu Pidiku. These are all the multiple instruction given to the patient by different technologists. But the recorded voice will be Shasam Nirtu. So patient is actually utterly confused what to do. This is what result if the patient is not obeying your verbal command. So these artifacts have come from where? It has come from patient. Why it has come? It's because your instruction to the recorded instruction was different. So as much possible, try to use the same instruction as recorded in the scanner. Very interestingly, when you're doing any complex procedure or angiographies, what I have seen is use of manual voice helps a lot. When you're putting the patient, you go inside the gantry room, put the patient on the table, talk to them, instruct them how to hold the breath. And when you go back to the console and give instruction through the microphone, patient already has created a mental relationship with you on your voice, and he will do much better than what the auto voice can do, right? So to win a successful study, manual voice work much better. And very important thing to remember is many times this is a constant mistake which I have seen across is when you have pediatric patient, please select the appropriate pediatric protocol. Never treat pediatric patients as young adults. They are not. Almost all scanner today has color-coded protocol. G system uses the Bose-Luton system of color-coded protocol, where depending on the BMI of the pediatric patient, we have categorized that into pink, red, purple, etc., different color levels, and appropriate protocols have been set there. So please use pediatric protocol for doing pediatric scan. It's not only the KVMA, but also there are so many other parameters are there within the scanner, like the bow tie filter or the scan field of view, reconstruction, slice thickness, etc., are determined by the appropriate selection protocol. And just again to remind you, remember, pediatric patients are not young adults. Just to summarize so far what you have seen, use of two scans helps a lot. It will help you to position the reconstructed FOV, as well as it can help in good MA modulation and reduce the dose by 30%. So please don't delete that second scout which you have put in the protocol. Use of right noise index, which you have seen 10 to 15 for soft tissue and 15 to 25 for bone or high density interface, gives you the adequate image quality. Limit the scan coverage to the appropriate region. Use of manual voice or auto voice, and it needs a lot of consistency. And of course, your patient need to be trained multiple times before you do a scan, because patient comes to the scan room only once, maybe in his lifetime, and it's our job to make a successful scan for him. So we should not compromise on that. And pediatric patients, they are never young adults, and select the right pediatric protocol. And many parameters in the scanner is selected by that. And please follow it. And patient centering, as you have seen, is a very, very important thing. And use appropriate patient centering of anatomy closest to the isocenter. Now comes the question of obese patient, what I will do. When true obese patient comes, Rather than searching for any parameters, please use the highest possible KV. Please use the highest possible MA and appropriate rotation time. Use all the possible noise reduction filters. Maybe that you can increase slightly the thickness so that you can offset the noise. And use of all this will help you to avoid a scan than repeating it with an additional dose to the patient. There is an example. There is a large patient came with 157 kg and 76 BMI. We have used a 0.35 second because it's a cardiac second scan, so I couldn't compromise on that. But what we have done is we have moved from 120 kV to 140 kV and used a very high percentage of iterative reconstruction. Of course, we didn't compromise on the volume of contrast what we have injected to get a successful scan. There are different technologies available today to reduce dose to the critical organ. One of them is organ dose modulation. It is nothing but an electronic shutter which will reduce the dose to the critical organs like breast or gonads or lens of eye, which are critical, they are very much dose sensitive. So you can use them to reduce the dose. The earlier technology was to use bismuth shield, but that used to give a lot of artifact. But with ODM, you can reduce the dose to a substantial 40 to 50% dose to the critical organs. Iterative reconstruction is something which has come as a recent update, almost a decade now, more than that. And use of iterative reconstruction helps to reduce the dose and improve the image quality. I'm not getting into the physics of how iterative reconstruction work, but just to say how it help you in your day-to-day practical aspect is the first thing is it reduces the noise. The first image is without iterative reconstruction, and the second image is with iterative reconstruction, and you can see the improvement in image quality and the noise reduction just by using the iterative reconstruction. This enabled ultra low dose chest scans today. You know that FDA has approved ultra low dose lung screening. So you can use a higher percentage of iterative reconstruction there in lung and a very low MA in terms of like 10 to 12 MAS can happily get a good quality image. Here is an example of use of iterative reconstruction. You can see one scan was done with 400 MAS and other scan was done with 200 MAS with the same noise levels. The first one is reconstructed with the conventional filtered back projection. Second one was reconstructed with the iterative reconstruction SR. And you can see the gray-white differentiation and the improved image quality with the lower MAS image compared to higher MAS image. That means to improve your low contrast detectability as well as to improve the dose reduction, iterative reconstruction play an extremely important role. And always use iterative reconstruction as much possible to improve your image quality. Here is a classic example. You can see 3 reformats in front of you. The first one was done with 50% iterative reconstruction. Second one was done with a soft algorithm with 50% iterative reconstruction. Third one was a combination of soft algorithm with iterative reconstruction of higher percentage, 70. You can see there is a marked difference in image quality improvement. I'm sure the radiologist may not accept the first image, whereas he will definitely accept the last image. Have we done a repeat scan? No. What we have done, we have intelligently put a higher percentage of iterative reconstruction to take care. And of course, a small tip in front of you, as I have spoken earlier, slightly I have moved from 1.25 mm slice to 2.5 mm in the reformat. Of course, there is very minimal partial volume effect, which is ignorable, but the image quality is drastically changed. It looked like absolutely great image with a higher iterative reconstruction percentage and a slight increase in the slice thickness. So in obese patient, use the best possible technology of MAS and KV and adequate volume of contrast. Please don't compromise. It's better not to repeat a scan than giving a higher dose to the patient. Use of dose reduction technique like organ dose modulation, they can reduce nearly 40% of dose reduction. And of course, iterative reconstruction, which is very, very strong in terms of noise reduction and the image. and they not only improve the noise but also improve the overall image quality. And many times they come as a great helper to salvage a very noisy study. So just to summarize, we have seen multiple imaging parameters in CT, which can be practically done by all of us, practically modulated by all of us to improve our image quality. Once again, thanks to the ISRT team and my dear community members, and very happy to share this with you. And thanks for the great opportunity given to me. Thank you so much.
Yeah, thank you, sir. They covered the topic in a simple and excellent way. I can say that really in a simple language too. So I think you gave a clear picture in the relation between image noise, role of MAS, KVP, city imaging, DFOV, SOFOV. So it was really an excellent talk for the technologies as well as for these radiographers. So we have given a clear picture of the advances also, advances which recent advances of different vendors using most of the new city machines. So I'm sure that your briefing had given our technologists to brush up their ideas and their knowledge in city imaging. And we have a couple of questions too. So I think we will go back to the questions. Yeah. So one question is how to reduce patient dose in pediatric cardiac angio. It was a question. So can you answer, sir, on that?
Sure. Sure. Am I audible, Mahesh? Is it okay?
Yeah, yeah, you're audible.
Okay, great. Uh, the question from Sandhya, right? Okay. How to reduce the dose to the dose in the pediatric cardiac angio? First of all, when you say a pediatric cardiac angio, one question I would ask whether are you going to do a gated run or non-gated run? What is the purpose of it? Mostly in pediatrics, you don't need a gated run as you are interested to see the great result. So it's better to go for a non-gated run to see the great result. And compared to a gated scan, a non-gated scan will give enormously low dose. Okay. So first of all, select whether you need to go for a gated or a non-gated run. Because we are not going to identify a coronary artery disease except one of your very limited condition in pediatric cardiac studies. As technologists, the most important thing is to use, as I said earlier in the slides, also to use lower possible KV, 70 or 80, depends on your system. Uh, and of course, use of right scan field of view. It depends on the vendor, depends on the system. If you have pediatric scan field of view, please use the pediatric scan field of view. That will bring more homogeneity of smaller field of view and will improve your image quality. So it's a combination of what the purpose. That's why I always say check the clinical task before you select a protocol. Check with the radiologist, check with the referring doctor who can give more light to throw more light to the clinical requirement, what they are looking at from the scan and the result what they are expecting. So once you know that clearly, then it's up to use the right lower KVP, possible lower scan field of view, and of course use iterative reconstruction as much possible. Okay, as much higher percentage as possible. Uh, and of course, very important thing in pediatric study is ensure that the pediatric patient is sufficiently sedated when you do the scan. Many times I have seen as you inject the contrast, especially in cardiac run, the patient jumps out, you already injected, few scans, monitor scans are over, and suddenly all of a sudden within few seconds scan is also over, giving no results. So I would recommend that as an second important things in terms of other than the scanning system is the patient preparation. So please ensure you have got sufficient sedation and supportive uh, equipment as well as supporting staff to enable it. Right. I think that answers there. Mahesh, over to you.
Yeah, thank you for the answer. And we have one more question from Joy. He asked, how low KVP reduces patient dose? And his question is from Joy. So his 100 kVp photolitry effect is predominant, and thus image quality in terms of contrast also must be uh, low. So, but radiation dose to the patient is higher when compared to high kV techniques. So, can you give an explanation for that, sir?
Okay. Uh, I understand this question. The question I'll repeat for the benefit of all. So the question from Joy is compared to he is compared with conventional radiography with CT, where in conventional radiography we say that lower KV when you use the dose is high to the patient, and that's why we use high KV chest X-ray. But you may lose your low contrast detectability or contrast latitude. You may lose your soft tissue difference in the conventional radiography when you use a high KV. That means, in nutshell, I can say use of high KV in conventional radiography will give a low dose. But when I presented on a slide, I said use of higher KV will increase the dose. Right? That's what is getting yourself getting confused. Am I right, Mahesh?
Yeah, that was a good
I think you're
answer.
clear, Mahesh.
So I think so. So we have one more question from Mr. Sanjeev Kumar. So he is asking about care dose and fixed KVP. I think it's a vendor-based
I'll come to
thing.
that, Mahesh. I'll come to that. I'll come to that. Okay. Before I need to answer Jai a little bit more. So Rai, sorry, Jai, we are not comparing conventional radiography with the CT. In CT, dose is measured as a standard at 120 kV and at 100 MA, and this value is measured using a phantom, which is a 16 centimeter phantom for the head and a 32 centimeter phantom for the body, and this is taken as a dose index. And as you know, if you increase the kV, what will happen? The photon flux will increase. If the photon flux increases, proportionately the attenuation will increase. That means absorbed dose inside the phantom will also increase. That's why when you move from a low kV to a high kV in in CT, will give a higher dose. Whereas in conventional X-ray, when you are increasing kV from say 80 to 140, doing a high kV X-ray, you are actually reducing your MAS. Okay. Here it is not happening. You are keeping the MAS as 100 for standard CTI dose measurement. Hope that answers. We can have one-to-one chat on that also. Okay. And Sanjeev's question also, Mahesh, I can answer. The question is care dose versus fixed KV. Okay. It's okay. Being ventral neutral doesn't matter, but I can say care dose is a technology where you are using MA modulation. Uh, and of course, we cannot. None of the CT system today can do a KV modulation during a single scan run. Uh, why? Because modulating KV will change the Hounsfield unit. So you cannot have the lower proportion of the brain having white matter having certain HU and the higher portion of the brain having a different HU. So there is nothing called modulated KV during a scan today. Okay, all KV runs on a fixed level. And then coming to Keros, of course, is MA modulation technique. We call it as auto MA, smart MA. Different companies call by different name, and in nutshell, we can call them all of them as automated exposure control. But once again, tell you, KV modulation on a routine day-to-day scan is not practical. Okay. Dual energy systems are a different story, but there the methodology of imaging is different. Let me add that also to you. Hope that answers.
Yeah, so that's all from the question side. So I hope it's a good series, good live series. It was a good live series because many commented. Their encouraging comments had made us proud enough uh, for organizing this type of event.
Yeah.
So
One question is there, Mahesh, from Rajesh is asking. In pediatric temporal bone imaging, how to reduce the dose? Okay. Very nice question, Rajesh. The thing is, we should use the lowest possible dose as you, I know you are a user of Revolution Evo scanner, where we have set it with slightly higher kV. I can tell you, I used it 120 kV. Because when you say pediatric, it's not really very small babies. Sometimes this age goes to 7 to 8 or even 10 or 12 years, and where already the bone is very thicker. So use of 80 kVp for those population may not give you sufficient penetration, or it may result in beam hardening, especially when you are imaging the uh, soft tissues in the IAC temporal bone area. But one thing which we have kept very intelligently there, we have used low MA, very low MA, and a very fast rotation time to take care of the motion artifact. The use of lower MA has helped a lot. In terms of two things, one, it reduces the dose. Second thing, use of lower MA will push you to go for small focal spot. Use of small focal spot is very, very important in your high resolution imaging, and for those parts like temporal bone where high resolution imaging is important. So use of lower MA, even though we have used a high KV to compensate for the beam hardening, use of lower MA will reduce the dose and it will improve the image quality in terms of improving the resolution. Yeah, thank you.
Thank you very much, sir. I think that's all from the question side.
Okay.
No question, I think it was. Yeah, that's all comments. Okay, sir. Thank you very much for the excellent talk which
Thank you.
you gave us. And thank you very much from ISRT. Thank you very much.
Thank you, ISRT team. Wish you all a great 2021. Let's be come out of this pandemic and be happy. And once again, thanks to the entire ISRT team. Nice sessions you are running. Please continue the good work. Thank you so much. Bye.
Thank you very much, Sundarji. That's all from the team ISRT. And we'll be back with another topic next time. Thank you for watching this live series. And I expect more talks, more topics from ISRT live series. See you next time. Bye. Thank you.